case of FFR Guided PCI in chronic cerebral angina. So the patient was a 50-year-old male who was a ex-smoker and dyslipidemic. He had presented with angina and exertion class 3 for the past 4 months. Echo showed a normal LV function. TMT was done outside, which was strongly positive with exercise capacity of 8.2 mets. His coronary angiogram was done outside, which has shown a LM ostial mild blacking. LAD mid had 70% stenosis and distal of 50% stenosis. L6 was dominant with a mild disease and RC was non-dominant. So this was the angiogram. Here you can see there is some mild plaquing in the LM ostium and there is a significant, say 70% disease in the LAD mid and some mild disease in the LAD distal. So since LAD lesion was not very tight and he was having class 3 angina, we decided to do FFR first and then proceed with the PCI if it is positive. So took a 6 of right femoral axis with a 6 of JL 3.5 guiding. So on engaging the left main, there was a ventricularization of pressure trace. So we decided to look at the IVUS in the left main to rule out any significant LM disease. So this is the IVUS of the left main. Here you can see at the ostium, the lumen area was 6.85 with a eccentric lipidic plaque which can be seen in the LM ostium. So since the luminal area was above the cutoffs, which is 6 millimeter square, and even for Asian standards, 4.8 millimeter square, so we assumed that LM ostium is not significantly diseased, and since the excess tolerance was not significantly reduced, we decided to proceed with FFR and if positive do LAD PCI. So this was the FFR. So this is the basal PD by PA, which was 0.84, and after adenosine got a positive FFR, which was 0.77. So we decided to proceed with PCI of LAD. So this LAD mid lesion was dilated with the 2.5 to 12 balloon and stented with the 2.5 16 mm DES and post dilated with the 3 mm MC balloon. And we repeated FFR again to see how well we done the PCI, but again you can see the FFR is still positive. It was 0.75. By the way, all these were intracoronary adenosine based FFR, no feedback was done actually, since we assumed that LM was not significant. So then we probably thought this distal LAD disease is causing the positive FFR. So we stented that with a Promo Select 2.5 into 28 and post dilated with the 2.75 NC. And this is the result, but again, FFR is still positive. So this time we decided we will give a IV adenosine infusion and do a pullback. And as we can see, surprisingly, the entire LAD, there's no pressure drop except for the LM ostium. And we confirmed it again by doing FFR from L6 to LM. Again, the same LM ostium was the culprit, despite I was showing a very good area. Since at that time, because of logistic issues, could not complete that PCI and called him after a month. He was still having the same angina which he had before the PCI. So again, this time we did a PCI of LM to LAD. Took a 3.5 into 24 mm DES, stented across the LCX and did a pot of 4.5 into 8 mm, opened the struts with the 2.5 SC and did a final pot. So post IVUS, LAD ostium area was 8.9 millimeter square and LM ostium achieved an area of 12 millimeter square. So then again we did a FFR. So this time it was negative, but however, normally you should expect a FFR of less than more than 0.9, which was not the case here, even though the FFR had become positive. But since the area was already achieved more than 12 millimeter square, we did post dilatation again. So on follow-up, patient's angina has reduced definitely, but still he has some angina and heavy exertion, which we have managed with anti-anginals. So in this case, basically it was a discrepancy between the LM IVUS based MLA and FFR. So probable explanation might be it's a left dominant circulation and that LM supplies a very large myocardial bed. So hence maybe the discrepancy between the imaging and physiology. Also LM had a diffuse disease involving the entire segment. So as you know, as the length of the lesion increases, the pressure drop increases across the disease segment. And there is some data to show that lesions with plaque burden of more than 60%, the FFR tends to be more positive. And here we can see it's a predominantly lipid-rich plaque, so probably that might have caused the discrepancy. So to conclude, angiography alone might be misleading in LM diseases. Intracoronary imaging should be done for all patients suspected LM disease. Imaging and physiology should be complementary. There may be cases where imaging might trick you and ultimately have to do a FFR to be very sure. And in chronic stable angina, FFR is vital in guiding PCI of correct lesion. Had we done this PCI without a FFR, would have just ended lady and come back and patient will come back again with the same symptoms. And FFR pullback is valuable in such cases where FFR is disproportionately positive in respect to angiography. And most of the times you end up doing intracoronary adenosine for ease of doing it, and instead of takes time to set up the infusion and all. So preferably do a IV pullback with the IV adenosine FFR to achieve optimal results. Thank you.